Welcome, everyone, to Dementia Unplugged. I'm Jeannie Forrest, the host of the show, in collaboration with the Dementia Society of America, and I am thrilled that you're here today to join us. Today, we're going to be talking about competency, consent, and involuntary dementia admissions. So stay tuned for, I think, a very important and interesting session. I'd like to start, though, with a little disclaimer from the Dementia Society of America. All content, including any potential medical information, is provided as an informational resource only. It is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult with your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by me, Dr. Forrest, and her guests are not necessarily the opinions and content of the Dementia Society of America. Thank you for listening to that. What I like to do is start any session with the term dementia, so we're all on, the same page. So the word dementia is really an umbrella term, and hence, the visual of the umbrella. It represents a variety of subtypes of diseases, conditions that present itself as a dementia. Like the word cancer, there are many different types of cancers. Like the word dementia, there are many different conditions that contribute to this dementia syndrome. At this point in our understanding, there are some reversible dementias, and that hence is the reason why it's so important to get a medical workup to see if some underlying condition, such as hypothyroidism, could be reversed. But on the flip side, and many of our dementias are not curable at this time. I like to say that they are, quote, treatable, especially if one looks at the environment and the support for individuals, and that includes things like music and art and exercise. And there are a few medications that help to manage some of the symptoms, but those are the, quote, treatments. But unfortunately, at this point, we're still trying to do our best in terms of finding the underlying reason why something's happening. Okay, so that's the basic piece. You may be more aware of the more common types of dementias, such as Alzheimer's disease, vascular dementia, and what makes it even more complex is one could have a mix of dementia. And then we have frontal temporal, and the list goes on. All right. So you are listening to a program called Dementia Unplugged Care Conversations. It's only one of the Dementia Unplugged versions. We also have Dementia Unplugged Musical Connections. This is an opportunity to listen to brain health scientists and performers, look at the benefits of very personalized music. It's a monthly enrichment program. It's on the third Monday of each month, and it's in partnership with Music and Memory. We also have Artful Insights. This is more of a casual opportunity to look at selected works from leading museums. It's also a monthly enrichment program, and it's on the fourth Monday of each month in partnership with the Arts Philadelphia. So you can really keep your Mondays quite busy here with the Dementia Society of America. Okay, so now let's get to our celebrated guest here. I want to welcome Drew Lazara, LCSW. She is now the Director of Behavioral Health through the Symphony Care Network. Drew is a licensed social worker with over, 20 years of experience working with older adults and their families. She graduated with her master's degree in social work from University of Illinois at Chicago. Yes, my alma mater. And since had the privilege of working with patients and families facing dementia. Drew has worked with the Amita hospital system as a geriatric clinical navigator for several years, assisting patients and families access inpatient behavioral health care. Currently, Drew is working with the Symphony Care Network as Director of Behavioral Health, where she is focusing on developing programs for older adults who are experiencing behavioral challenges as a result of their dementia. Okay, that is a mouthful, but a wealth of experience. And so now I'm going to stop my sharing so that you can just see the two of us for the time being. Please know, if you're new to this, that this is recorded, and I'm going to pause sharing here. Okay. There we are. I love the technology. It's always the most anxiety provoking for me in any of these sessions. So welcome, Drew.
Thank you. It's so good to be here.
Oh, and thank you for taking your valuable time. This is important. And this is recorded. So for people who can't see the live version, they'll be able to see a recorded version. So let's get started, and we'll talk for about 30 minutes. In the audience after that, I'll open it up to the chat button through Q&A, and then you can enter your questions. So Drew, tell me a little bit about your background and what sparked your interest in particularly behavioral health.
So growing up, I grew up in a small town in central Illinois, Charleston, for anyone who's familiar with Eastern Illinois University. That's where I grew up. My mom was sort of the person in town that took everyone under her wing. And we spent most of our weekends visiting the 3 nursing facilities in town and just checking in with people and just kind of seeing how everyone was doing. So from the time I could walk on my own down hallways, I was going into nursing homes and just finding people who looked like they might be interested in chatting. So as I grew up, we did this all through high school. And when I went to college, I decided that social work was maybe the way that I could parlay this into something as a career. And that is absolutely what I've done. I have worked in and with nursing home populations and specifically dementia for my entire career. And so the behavioral health component for me was all about helping to understand behaviors in dementia and how we can manage them and treat them so that families could best experience their loved ones as they fought this illness, and so that the patients themselves could have their highest quality of life. And so that's kind of how it just sort of happened from the beginning.
Yeah, it's often from a personal history to some extent that we enter into this field particularly. So I get that. So you're well suited and you were brought up in this world. So okay. So let's get started. a lot of confusing terms, I find, even if I'm in this field, and this is so confusing to me. What does involuntary hospitalization mean?
Oh, that is such a big term and a scary term, I think, for something that is actually not as scary as it sounds. What it really means is in America, we really want to protect everyone's freedom and everyone's rights. That's what we're about. That's, kind of what we believe as a country. And so there are a lot of laws about what you can and can't do in terms of restricting someone's rights who has a mental illness. And that includes being able to put them into the hospital. So, involuntary admission to a behavioral health hospital, the laws around that are focused mostly on individuals with severe mental illnesses like major depressive disorder, psychotic disorders related to maybe a bipolar diagnosis or a schizophrenia diagnosis. So when it comes to people with dementia, the laws don't always line up well because they really weren't taking those individuals into consideration when they wrote them. So when we talk about involuntary admission for someone with dementia, we have to follow a lot of those same laws in terms of what we're allowed to do in terms of getting someone help at an inpatient level. So involuntary admission means that someone, could be anyone, it could be a family member, it could be a clinician, a physician, it could be a police officer, it could be anyone, observes behaviors that are putting the person or someone else in danger, that they're at risk of hurting themselves or someone else. And at that point, we then have the legal opportunity to have someone go into the hospital to be evaluated and treated for those behaviors. For a person with dementia, it's related to their dementia, typically.
So I want to just probe a little bit more because what I see, unfortunately, is there's a big vagueness into what that really means, harmful to themselves or to others. I've seen people potentially being considered for in an involuntary hospitalization when they're just resistant to care.
Right.
and so there's a big, I think, misunderstanding of what that means. So can you paint a picture of a person? What would they be having to do before you really should be considering this?
Absolutely. And just for the purposes of this conversation, we're going to always assume that we're talking about somebody with dementia. So
Yes.
this doesn't apply to a person who might be a younger individual who's suicidal or things like that. We're really going to focus on the person with dementia. So what you see when a person qualifies or is eligible to go into the hospital for inpatient involuntary hospitalization is pretty significant physical aggression. So if a person is resisting care to the point that they're punching their caregiver or punching their family members, they're just so physically aggressive for any reason, that is a qualifying behavior because you're not able to control that physical aggression and you don't know how far it will go. So that's one. Sexually inappropriate behaviors, especially in a public or communal setting. So a lot of times with our dementia patients, we'll see less filter, right? There's less social inhibition. And so sometimes you'll start to see sexual inappropriateness. They may be coming on to someone who is not interested in those advances, and then they can get kind of forceful about that, or disrobing, or public nudity, those kinds of things. Also, it puts them at risk in a public situation. Sure. So those kinds of things would also be something you might consider. And then verbal aggression with threats that you believe the person is capable of following through on. So sometimes what we'll see is a husband and wife living together, and one of them has dementia, and they get very paranoid about what might be happening in the home. You see this a lot with Parkinson's dementia. And someone might be very paranoid that the spouse is cheating on them or what have you. If they get very verbally aggressive and threaten specifically to harm you, and you think they have access to that way to harm you, and you think that they might actually follow through, that would also qualify as being able to be into the hospital.
Thank you. Thank you for that. And I'm going to put in sort of my interpretation at this point to who's ever listening at this point. There are non-drug ways. So, my expertise is in teaching families and caregivers how to prevent it from getting to that point. So I don't want people to think that people with dementia, that's quote normal. There's usually a poor approach. There could be an underlying infection, a delirium, pain management. So there's often things that I think we have to check through, and don't assume, well, every time someone gets like this, but this is an alternative. But I guess I want people to understand this is kind of an extreme measure here.
And I would so agree with that, in that when these behaviors are presented, our goal, our intent and desire to assist would be to ask a whole lot of questions about, was this going on? Was that going on? Have you tried this? So these behaviors that I just described, what we would expect is that these behaviors persist despite all of the things we know to do to try and manage them. I would agree with that. That's an important caveat.
Yeah. Okay. So this is happening. So I'm just going to visualize. You got the person who's extremely paranoid, or thinking someone. I had this happen. The father with FTD thought the son was a potential lover of the wife and went after the son. Sad scenario. And so you call the police. How do you make that happen into the hospital?
Yes, this is the most challenging part. So for people living at home, so we'll assume that we're talking about people living at home for this question. There are a couple of things that you can do. There is always the call 911, and especially when the situation has become so out of control that people are fearful, right? Your fastest thing to do is to call 911 and get someone there to help you. And at that point, you'll explain that these are the behaviors that are happening and that you would like to complete a petition for involuntary admission. That's the language. So there's a form, it's a legal form that you must fill out so that the paramedics can take someone to the hospital. Now, that doesn't have to be done before they take the person to the hospital, because it can be done in the emergency room, which is where a person will go if you call 911. And then you can work with the social worker at the emergency room who will help with that process. So that's the most common thing that happens in these situations.
Do you have to be the POA at this point to do that, or could be anyone in the household can do
It can be anyone in the household.
Okay.
It can be anyone in the household. Anyone who observed the behaviors. So sometimes maybe you've got a private duty caregiver that's helping out at home, and it's the private duty caregiver that experienced this or is in this position. It can be the private duty caregiver that completes the petition. So it's really anyone that observes the behavior.
So the person shows up in the ER you're going through your assessments, correct?
Yeah.
And then what's the criteria, or what happens to say, no, they need to be hospitalized. This is not a UTI that we can treat, or so what does that look like?
Yeah, just to be clear, this is one of the most difficult processes a person can face. So I want to acknowledge that anyone who's been in this position or who has faced this position, if you felt like, oh my gosh, that was a nightmare, it's because it's really, really tough. It's a nightmare, which is why I'll throw in here now. It's really helpful if you have a resource, someone who's familiar with the process that you can call to just help you work through it. I'm available for that, just for anyone who happens to have my phone number and wants to call, because what happens in the emergency room is your loved one, your person, often has a bit of a reset that occurs from the home in the ambulance ride to the emergency room. Like any of us, you take my environment and take all control away from me, and now I have to take a ride to the emergency room. Everything I was thinking and doing now is different. I'm not any longer focused on maybe the person that I was so paranoid about. I've been removed from the environment that triggers me. So sometimes when they arrive at the emergency room, all of those behaviors that you're describing, no one sees them. They're calm and they're cooperative and they're like, just send me home. So.
And the family members saying, no, really?
No, it's really happening.
Yeah.
So yeah, that's a very difficult thing. So a couple of things to be mindful of. One, the more specific you can be in your description of what was happening, especially when completing that form, the more important that will be. There will be times that the doctor will evaluate and the social worker will evaluate, and they'll say, we can't justify this. We understand what you're describing to us, but we are seeing zero evidence. And that does happen. And so I just want to acknowledge that. However, there are as many times when you get to the emergency room that even though it may not be as pronounced, there are still ribbons of that paranoia or ribbons of that agitation. And so you want to explain to the social worker kind of what causes that and let them ask some questions that may draw some of that out a little bit so that they can see how the person's thinking is disrupted. And at that point, they'll help between you and them make the decision about whether or not hospitalization is necessary.
Things have bubbled up in my head because I can recall going through this with a couple families. So we live in Illinois, but is this nationwide, this process, or is it different from state to state with mental health laws?
It's different. It's different from state to state. Of course it is. Now, I mean, there are similarities. Every state has a process for protecting people. Some things are more strict than we have here in Illinois. Some states are less. But to some degree, this process exists in every state. There's a process for moving through. And it's difficult in every state for especially those experiencing a dementia crisis.
And on top of it, with COVID, right now, the waits in the ER make it more complex. So this isn't to make everyone depressed who's listening to this call, but this is the unplugged version of this situation. We talk about the difficult.
And this is where I say, because sometimes I think we get to this stage in the conversation and people go, yep, and they kind of tune out because they've had an experience and they're like, well, she's just telling me exactly what I already know. It's too hard. This is the point in the conversation where I want to say, find an advocate. there are advocates out there to assist you, and there's all different levels of advocate. That some that are a private pay option, so that you can have more services and more assistance in navigating a really, really difficult arena. But then, like I said, there are people like me. I'm not the only one that for her day job is allowed to field calls specifically when there's a need for hospitalization. And when we wrap up, I'm going to make sure that Dr. Forrest has some of that information so that it can be sent out to you guys.
Yeah, if you can send it out to the chat, you can.
Yeah, because that's a huge component of this, is just being able to have somebody who has done it before and knows some of the language.
Thank you for that, Drew. So, okay, so let's assume, okay, now they are going to be hospitalized. So now what? So I remember there took a while to find a hospital, number one.
Mm-hmm. Mm-hmm.
And now they're put in a psych unit, correct? Mm-hmm. Okay, so take us forward from that.
So this is really important. So we've gotten through all the difficult part, quote unquote, and now we've got an admission. Someone is admitted to the hospital. And many of you have experienced working with a hospital before in some way, shape, or form. Maybe there was a medical admission, or you've had experience. A psychiatric admission is a little bit different. So once a person is admitted to the inpatient behavioral health unit, there is a period of time where they need to be evaluated before anyone from the hospital can actually communicate with even the power of attorney, the family or the power of attorney. So this is really important.
And a lot not known. Trust me, this is not known.
Yes. So it's a huge frustration for families because they don't understand that they had their loved one admitted to the hospital and now no one will talk to them for like 24 hours. Like they get no communication. And this is unusual because in the medical hospital, you're allowed to stay with your person. I mean, COVID has created some problems there, but communication is relatively free flowing on the medical side. But because of our mental health laws, there are some really strict standards that have to be followed when a person is admitted psychiatrically. And this applies to dementia patients as well. So this is my plug for having your power of attorney paperwork in place.
Okay, everybody listening.
Have it in place early. I'm 41 years old. My power of attorney paperwork is in place. Like it's done, So we want to make sure that you have a power of attorney in place. Why? Because when your loved one with dementia is admitted psychiatrically, the psychiatrist has 24 hours to evaluate the individual and determine whether or not to enact the power of attorney. The power of attorney in a psychiatric setting is only enacted if a psychiatrist evaluates the person and deems them unable to make their own decisions at this time. So they have to be having, behaviors or impaired thinking that leads the psychiatrist to believe, yeah, we need the power of attorney making decisions right now. If your loved one is one of those individuals, maybe with a vascular dementia diagnosis and kind of comes and goes in terms of lucidity, if the psychiatrist evaluates them and they're pretty lucid in the moment, then the power of attorney is not going to be enacted that day. And your person has to sign a consent for individuals to be able to communicate with you. So we share this because people don't know it and they think that information is being withheld. And that's not the case. We have to follow these mental health laws. Mm-hmm. That said, there is no law that prevents you from calling the hospital and giving them the information that you think will be important for them in the evaluation process.
So this is the advocacy piece.
That's the advocacy piece. So when your person is admitted and you call the hospital and you say, I'd like to speak to, Audrey Smith's nurse, and they say, well, we can't confirm or deny that Audrey is here, then you say, please put me in the voicemail of a case manager. Any case manager, doesn't matter. They will put you in the voicemail of your person's case manager or someone that will be able to transfer that information. And then you give them all the information. You leave your message and you say, this is what was happening. This is what we've been experiencing. This is the timeline. This is what we know. That information will then be considered while your person's being evaluated.
So it's that consent piece that, in my experience, the person has lack of insight in terms of safety awareness, lack of insight that anything is wrong. Thank you very much. What are you doing putting me in this place? And they don't sign the consent.
Right. And that does happen. That does happen. But then usually what will also happen is that, and this is what's frustrating for families, is that you can't speed time up. But usually what happens is after they're there a day or two, the doctor sees them every day, every single day. So after a day or two, the doctor starts to see those same holes, those same insight gaps, those same safety awareness gaps. And it's once they're able to see that a little bit that they can then enact the power of attorney.
So before I open it up to questions, because so one of the scenarios I'm painting is that the person refused to take any of their medications.
Yes.
And which potentially could have prevented some of this issue.
Yep.
So when they're hospitalized, the idea of forced medication, giving it injection wise, just talk a little bit about what people in inpatient psych can and can't do.
Absolutely. And one of the things that we did talk about at the very beginning is this idea of refusal of medication or refusal to eat, refusing care to the point that it is harmful. That also becomes a criteria for hospitalization. So when a person is refusing care to the point that they're not thriving, they're not healthy, then you can also look at hospitalization. In terms of forced medication, this is a hugely controversial issue. And I want to assure everyone that, first of all, forced medication from a standpoint of someone who's got an enacted power of attorney, the power of attorney is the one who makes those decisions. It's not the hospital. I have yet to see the hospital go to court against a power of attorney's wishes. We go to court for younger people who don't have a power of attorney or someone to make their decisions, and then sometimes the court makes the choice. But for an enacted power of attorney, you guys are active participants. And forced medication, it will be explained to you depending on the type of medication that we want to use. But a lot of times the medication that they recommend as forced is really a long-acting injectable medication that treats psychotic symptoms. So those paranoia kinds of things, the delusions, the hallucinations, the things that are really getting in the way of a life lived well, even with dementia, those are the kinds of medications that we are often talking about. And oftentimes they want to do a trial of something shorter acting to make sure that there are no negative reactions. And then they ask for permission to do an injection so that medication lasts long enough for the person to be free of those symptoms and then maybe be able to take their medication more willingly.
Yes. Wow. Thank you. Thank you. Thank you for that.
Yeah.
What I'm going to do now is just look at the chat and the QA and see what's coming through here. So let me just take a look at the chat. Is it legal to record on your phone the behavior when it happens in the home or elsewhere to show the doctors, therapists, social workers at the hospital?
So I won't speak from a total legal standpoint, as I don't have that background. But what I will tell you is that you can record someone on your phone to share with a clinical team. My understanding is that that can't be used legally. It can't be like used if you had to go to court for guardianship or something like that. But if you're just trying to use it to explain what was happening, to be able to give a visual, I do believe that you can do that. How much weight it carries depends on the person that's evaluating the situation. So you can do it, but it doesn't hold much weight legally.
Thank you. This person was working with a caregiver who was in danger and explained this similar process, I guess, in Michigan. She was asked to call APS. I don't know what that is.
Adult Protective Services.
Thank you.
Probably.
Thank you. I should know that. Yeah, she was so
Yeah.
grateful, and her husband was placed in a psych unit. So that looks like a good a good happy ending at this
And
point.
that's an excellent resource. Adult Protective Services or your local Catholic charities, kind of find out in your community who manages any crises with older adults. And those are great resources when you find yourself in this predicament. They'll come out, they'll do a home visit to try and help make some accommodations. So Adult Protective Services is a great resource when you need that help.
And of course, okay, hang in there. I hit the wrong button, not wanting to do that. Okay, so we're in the questions and comments. Drew, can you see that while I'm talking, can you go to the QA piece?
Sure.
And see what other questions are coming?
Sure. Is it free assistance to caregivers who desperately need help with the Medicaid process, which is frustrating and stressful? Great question. Okay, so when you find yourself ready to apply for Medicaid, there absolutely is free assistance for completing that incredibly complicated application. And again, that often lives in that Adult Protective Services, or if you have like a senior center nearby, somewhere that's catering to the seniors in your community, that's where you want to go, and they will they'll help you with that process. Absolutely. The second question in there, and we already did that one. Is it legal to record this behavior? We talked about that one.
Yeah, I knew there's always going to be some technical things, so I hope people are smiling like I am, because I can't seem to get back to this. So, okay. Any other questions okay, well, I'm thinking of a question. What if someone doesn't have a POA in advance? How much more difficult is this?
Yeah, so it's a little more difficult. It's a little more difficult because what happens if a person is hospitalized, goes into the hospital and is deemed unable to make their own decisions, then we need to find someone who can make decisions for this person. But because a person is no longer able to make their own decisions, they can't sign for a power of attorney because they're no longer able to make that decision. So
right.
It's super frustrating. So what happens then is families find themselves in a position to have to go for guardianship. And guardianship is a legal process. You need a lawyer to help you. You need an elder care attorney to help you with this. And you actually have to go to court to kind of prove that this individual needs a guardian. It usually goes relatively quickly, and it's actually a lot easier to initiate once a person is in the hospital psychiatrically, because you need a psychiatrist to complete a form called the CCP 211.
Wow, okay.
CCP 211. So the psychiatrist completes that form, and they can actually help to initiate what we call temporary guardianship while a person is in the hospital. And that's just going to the judge and saying, we have a family member, they're willing to do this. I've completed the form saying that it's an appropriate person. And the judge usually then grants what we call temporary guardianship, while then you can work with a lawyer to complete the process.
Whew, okay, but thank goodness there are steps, there are ways to get through this. But all of you who are listening, please, please, please focus on getting the POA up front, while the person can still make that decision on who they trust in order to make decisions in the event they can't. Wow, that's a lot of information, and I wish I can get back to your your face, but I'm afraid I'm going to discontinue all of it. So, is there anything else that I missed that you want to emphasize before we close here?
I think most importantly, I see someone in the chat saying it's so hard to get services if you don't have money, if you don't have dollars. And I would agree that is definitely difficult. It's always harder. But here's what I would say. Seek out your resources. There are a lot of resources out there. Sometimes they're just hard to find because you have to go digging for them. So find out who your senior services provider is, your senior center. Find out in your community who that is. Make friends with them and ask questions. A lot of times people who do what Dr. Forrest, what I do, we don't have all the answers, but we've amassed a network of people and can often reach out to someone who might be better equipped to help. So I think the thing that I encourage everyone to do is don't be afraid to call someone and ask a question, even if you're not sure they're the person to have the answer. Most of us just want to get you to the right place. We just want to help.
Oh, thank goodness there are people like you with this expertise. Now might be a good time for you to put your contact information in the chat button.
I am doing it now.
And yes, we'll see how we can get you in on the Dementia Society of America DSA resource list too. So
my phone number and email will be up for you guys. And again, I may not be the person that you need always, but I will definitely be glad to help figure out who is.
Thank you. All right. Well, that's a lot to ponder, a lot to consider, but a wealth of information, I think, that is going to benefit many of the families and clinicians on this call. So, again, with great gratitude, appreciate your time.
Absolutely. Thanks, everybody.
Yeah, so I just want to say, again, thank you to the Dementia Society of America for hosting this program. For those who are unfamiliar, please go to DSA website, take a look at all of the numerous amounts of information. And if you are able, consider donating to support this.
Oh, you know what? They're not seeing the info, and I think it is because I only put it out to the panelists. I did not see.
Oh, okay. You want to
hang on 1 second, everybody. It's coming. Okay.
Come to the chat button.
There you go. Yep. Technically challenged myself. Okay, there we go. You should all be able to see it now.
I've been doing this almost 3 years, but I always expect something to come through if I hit the wrong button. So my goodness, keep a sense of humor about yourself. So all right, let's see if there's anything else. I think that is it, and I will encourage people to join me again the first Monday of each month, and typically it's 10 a.m. Central Time. So again, Drew, thank you for your expertise and all that you do, and thanks to everyone who's been on this call and for your patience with my technology expertise here as well. All right, everyone, take good care. See you next time.